Surgical UBE for the ones that are starting is not very difficult. It's not something that you should start with, but technically it can be easier than the lumbar spine because you have much less bone to take out, and it's a very straightforward procedure after you get used to it. And of course, the multi-level decompression is where the big advantage is, because you can do with the 3 skin incisions decompress all spine if you want, all cervical spine, till the cervical thoracic region. You can, here's another example in situations, for example, like these multi-level cervical approaches. You see all the yellow ligaments still attached. I do my bone working first, 2 levels, then I do 1 more portal, and then I start to advance with the other portal, the other level decompressions. As I told, I never use more than 3 skin incisions in cervical spine. In 1 to 3 levels, 2 skin incisions. After 3 levels, I add 1 more skin incision. In this case, it was a C3, C6, I think, laminectomy. And it is possible to visualize and confirm decompression across all 4 levels without changing the cervical portal. As you can see here, I'm checking with the same portal all the 4 levels in the end of the surgery. And of course you have all these 3 skin incisions only in the post-op MRI. And also the CT scan, which I actually find more interesting, because if you look at what was done, it was not a laminectomy, but rather ipsilateral laminotomy, while the attachment of the spinous process of the contralateral lamina and lateral mass remains preserved, which is something that it's also not possible with the microscope, that you have to do a typical laminectomy or a laminoplasty, of course, for these cases. In non-contiguous levels, when you have problems in the cervical spine that are not in adjacent levels, here is also a problem with the microscope. With the endoscope, not so much, because effectively you can reach all the levels above and below with the same skin incisions, adding 1 more and taking advantage of the middle incision to work in both levels that you want to reach. Just talking about other approaches, other options in UBE, starting with revision cases, for example. Revision cases can be even easier, honestly, by endoscopy than by open approach. Nowadays, I think I'm a little bit more afraid to do revision cases if I have to open than if I have to do by UBE. This is, for example, a revision case of a previous UBE. This is normal speed for a Portuguese surgeon. I'm just kidding. I know that the fastest surgeon in UBE in the world is in the audience today. And I want to give him regards regarding that. It's amazing the way he operates. But here you can see that the technique stays the same. You can see clearly the fibrosis. You take out a little bit more bone to reach the natural disinsertion of the remains of the yellow ligaments. Try to take away outside of the fibrosis and go from outside to inside the fibrosis, and the procedure starts to be easier in this way. And regarding thinking outside the box, I show you here also, for example, this case that was done in less than 1 minute, a removal of a broken spinal anesthesia needle, a simple procedure performed very fast. That it's something that you could be more afraid with a microscope, and here it's a UBE, but it's just 1 incision. So you can think outside the box to see which cases are better for you to proceed with the endoscope. In this case, we have the opposite, a very complex pelvic fracture in a polytrauma patient. For those who don't know, I'm an orthopedic surgeon. So this patient was previously operated on twice by urology and twice also by general surgery for a rupture of the rectum associated with the release of feces into the pelvis, poor skin conditions for open approaches, where we decided to perform all anterior and posterior approaches percutaneously, and including fracture reduction with fantastic visualization capacity of the sacrum. This was 3 weeks after the trauma, so a lot of tissue. I had to do the debridement of the sacrum fracture by UBE, and then we can clearly control the reduction of the fracture, which is really hard to do it with an X-ray in this location, and we can use the same instruments and we are used to use with a pelvis fracture, as you see here in the image, and control the reduction. And I think it's a good option also for this type of patients and some patients of trauma, pelvic trauma and spine trauma. But of course it's important to respect this term. microendoblending, which is you respect the learning curve of endoscopy in order to increase gradually the percentage of procedures you perform this way while maintaining tubular surgery for cases that you do not feel comfortable yet performing by endoscopy. So to finalize, I think it's important, especially for young generations of surgeons like myself, to carry out a mental exercise and try to understand the trend in terms of technological, in terms of surgical investment, and try to anticipate how an herniated disc will be operated or a lumbar decompression will be done in 10 years from now. And you can say that tubular surgery is fine and the microscope is fine, and it is. It's an amazing technique. It's a technique and it's a weapon that changed the way that we see spine surgery. But if you stick to there, you might face the typical Kodak moment, the company, the largest photography company in the world that basically disappeared because it refused to transition to digital. And this is my typical experience, my personal experience for how long will it take to master all endoscopic procedures and stop doing microscopic surgery, or almost stop doing it. This is my graphic. I started doing UBE. It was in the end of 2021, but I put it here the beginning of 22. And only 2 years after starting, I was already doing 100% of my procedures by endoscopy, and I was decreasing gradually the procedures that I do with the microscope. Here I'm just putting decompressive posterior procedures, not all the approaches in spine. So where do microscopes still win? In my opinion, anterior cervical surgery. For me, I don't see a big advantage of using UBE for ACDFs, for example, when you have a microscope or a loop, even if it's less expensive, because it's less expensive with a microscope or a loop. Anterior approaches in general, thoracolumbar approaches, deformity, of course, tumors, and certain complex cases, UBE still isn't winning comparing to the microscope, but in most typical cases nowadays I do around 80% of my spine procedures by UBE. And to end, I could not fail to invite you all to the third ISUBE masterclass it will be held in Italy, in Naples, April 2027 is the masterclass of the European Society of Unilateral Biportal Endoscopy. Thank you very much for this time.
I don't think so. Thank you, Dr. Eduardo. That was a wonderful presentation. I hope we'll meet soon sometimes. Thank you for being there. Thank you very much. Now,
so moving on to the next speaker, I would like to call upon Dr. Vishnu Babu Thapa for his talk on revision lumbar spine surgery UBE technique.
Excuse me, there is one announcement to make. As we are running late, so I request all the presenter to stick with time. Thank you.
Sorry, there is another speaker remaining. Okay, you will continue with the talk.
Good afternoon, everyone. So next 10 minutes, I'll be speaking on revision lumbar spine surgery. Obviously, a revision spine surgery that fall under complex spine surgery. It falls under complex spine surgery because there is high risk of complication. The complication is because of the fibrous tissue or scar due to previous surgery and distorted anatomy. So what is in literature? In literature, the most common cause for revision surgery is recurrent disc herniation. Almost 2/3 of the cases, the cause of revision is recurrent disc herniation. In revision surgery, the complication risk is almost double the primary surgery. And among all the complications, the incidental duotomy is most common complication. So all the revision surgery that we can do by the open technique or minimal invasive technique, there is an article published by Kang in 2020, and he mentioned that there is significant improvement in the back pain and there is less complication by the minimal invasive technique. That is either tubular or endoscopic technique. So in the morning session, there is a lot of talk on whether midline or paramedian incision, but in revision surgery, paramedian incision is preferred. So these are my patient picture of the same patient. The first one is just once I create a walking space, there is a lot of fibrous tissue. And in the second picture of the same patient, that is after removal of the superficial fibrous tissue and some part of the bone. Because in revision surgery, we need more space. For that, we have to remove the bone from the lamina and the facet. So regarding the revision surgery, the approach should be between the facet and the traversing knob root, because that is the area where less fibrous tissue is formed. And obviously, a paramedian incision is better than the midline incision. And once the anatomy is clear, like in second picture, then we separate the fibrous tissue from the lamina and the facet with the help of the angle curette. So this 36-year-old lady had microdiscectomy L4-L5 8 years back, and again having a complaint of back pain with the right radiculopathy for 6 weeks and failed conservative treatment, and there is a neurological involvement, and VAS is 6 leg VAS. And this X-ray looks normal. There is MRI picture. We can see there is a PIVD L4-L5 on the right side. So video please. So in this case, I did So as I've already mentioned that first I remove all the superficial layer of fibrous tissue, then remove the lamina and middle facet so that there is a more space is created. And after the clear anatomy, there is a separation of the fibrous tissue with the help of the angle curette. And this fibrous tissue, this is called the post-laminated membrane as well. And that is the protective layer. So we have to be very cautious to remove that fibrous layer. It is better not to remove. If you try to remove the fibrous tissue, there is a technique, pull and cut technique with the help of the angle RAF. Then only, so once you release the fibrous tissue, then retract the traversing root along with the fibrous tissue more medially, then you will see the disc space. Most of the time, the disc is sequestrated and it will come on its own with the help of the pituitary. So it is difficult to get the discs in single piece. So usually most of the time the discs we take out in piecemeal. So there are multiple pieces. So we have to check with the help of the probe in multiple times. So once you are sure that all the discs are removed, then I usually do annuloplasty in each and every case. So I did an annuloplasty. So the patient post-operative, the patient is neurologically significantly improved, and these are the post-operative MRI picture, and there is a significant decompression. Next slide. Next. Next. This is another case, 36-year-old male female with a 5 years ago had a history of microdiscectomy, L4-L5. Again complained with this back pain for last 6 months with a right radiculopathy. And again, there is an MRI picture. This shows the L4-L5 right-sided disc prolapse. So, video please. So again, the technique is same, that first I remove all the superficial layer and remove some part of the bone from the lamina and the facet, then create an adequate space and separate the fibrous tissue from the lamina and the facet, and then mobilizing the traversing root and retract it medially and remove the discs. So once ensured that complete removal of the disc, I did the annuloplasty. Uh, So usually the disc comes in piece, we remove on piecemeal rather than in single piece. Sometimes last piece comes out, but still some more piece will remain. So always make a habit of checking with the probe multiple times. So again, I did annuloplasty. Next. So the patient is significantly improved clinically post-operatively, and MRI picture shows there is adequate decompression. Next. Okay. The surgical tips regarding the revision surgery is first we need an adequate space. So the space, so we have to remove the more bone to create a more space. But at the same time, we should consider the instability as well. If we remove too much bone, then sometimes may lead to the instability. And another thing, there is we give the paramedian incision for the two regions. First thing, we will have a less exposure to the previous surgery scar, first reason. And second reason is we'll keep our scope and instrument in preserved lamina and facet. That is the region that in revision surgery, the paramedian incision is preferred. Then next is separation of the soft tissue from the lamina and the facet. That post laminectomy membrane, which is nothing, this is a post-operative scar tissue that acts as a protective layer. And if you want to remove that fibrous tissue, there is a pull and cut technique. That is, you need a hook RF, and first hook the fibrous tissue and then cut and then coagulate. That is the technique to remove the fibrous tissue. So regarding the CT scan, if the surgery is performed by you or your center and you know that how much bone was removed in the previous surgery, you may not need CT. But if you don't know how much bone was removed or the surgery was performed in the other center or by other surgeon, in that case, it is better to do a CT scan to know how much bone is there. And always, bone is a fixed structure, so always when you mobilize the soft tissue or epidural space, always your bone will be landmarked. So first, feel the bone and do accordingly. So with this, the take-home message is UBE could be a safe and effective minimal invasive approach for complex lumbar spine surgery with a good clinical outcome, and we can prevent the spinal instability as well. So thank you.
Thank you for your wonderful talk. Because of time shortage, we will be taking only one question from the audience. Hello.
So I did not do many revision cases and not faces this dural tear. But in primary surgery, I face incidental durotomy. In those cases, I faced only 2 cases, but I did not do anything, but no complication occurred.
Thank you.
Usually, I do not do anything for the incidental, because in open surgery also, it's even in literature, it's mentioned that in degenerative cases, even there is durotomy, you don't need to do anything small. So even in open case, this is minimal invasive. So I think small durotomy, it is not required to do anything.
Yeah, you're right.
If you open to repair, sometime you may not see the even tear.
Exactly, you're right. One other thing which I felt while doing the recurrent surgeries, redo surgeries, while you are going in, the lower lamina is usually intact. So if we aim for the caudal lamina and do our dissection from that area, so it would be safe to have to avoid those durorans. That's my personal experience. I don't know how you see that, the recurrent cases.
It's not clear, please.
So I said, while doing the recurrent cases, if we start our dissection from the caudal lamina, from the lower lamina, because most of the time that is saved, that is not been eaten by the previous surgery. So if we start from the caudal lamina, it will be easy for us to do the dissection and to avoid those dural lines. That's my personal experience with these kind of recurrent discs.
But what I do is, first I feel the bone. So first I remove the superficial layer, and I remove more bone from, I usually start from the inferior lamina of the inferior border of the superior lamina. I'll come laterally. I'll try to remove the inferior facet as much as possible, and even the superior facet, some part, so that I'll get the area where there is no fibrous tissue. That's how I do it.
That's great.
Thank you. Thank you.
Vishnu. Next, I would like to call Dr. Ashutosh Kumar for presenting on UV spectrum of pathology, defined need-based exposure.
This is a small video that demonstrates how the evolution has happened on Earth, and I can tell you this is the way the technique in spine has also evolved. There has been a number of lives, different forms of life forms that has been on Earth, but one life form survived and it is presently dominating the Earth. So what was the reason? So what we can learn from this evolutionary processes, it is not one who is mighty, who is big, or has the intelligence that survives, but rather it is someone who has the ability to survive in all sorts of conditions. That is what is versatility, and that is the spectrum that any technique has to have so that it can survive for long. So good afternoon everyone, rather good evening now. I am Dr. Ashutosh Kumar. I am Associate Professor at Department of Neurosurgery, SGPJ. And at the outset, I am thankful to Professor Nikunj Yogi for having me here. These are my credentials, and I have no conflicts of interest or disclosures. So in next 10 minutes, I'll be highlighting why UBE is a very potent and powerful technique, and how it is truly expendable and will allow you to address not only a single level, a single pathology, but a varied spectrum that will give you the power to have one technique that masters everything. So to begin with, it is important to understand the science that is behind all these techniques. Once you understand the science, it is always possible to expand it to the newer horizons. So I'll be discussing some of the cases where we have tried to expand and rather push our boundaries so as to expand the spectrum of the technique, that include application of UBE TLIF in high-grade lysis, that is like grade 3 and grade 4, using UBE in cases who have bilateral symptoms where we have to do a bilateral decompression, then expanding it to posterior cervical foraminotomies, doing a decompression especially in cases who may have anomalous anatomy, then going to an ultra-minimally invasive technique where the flavum is also preserved, and lastly, expanding the horizon to the craniovertebral junction where we are using UBE for doing foramen magnum decompression. So to begin with, UBE TLIF for high-grade lysis. Before that, I would like to highlight one important point is, what is the possibility and what is the basis that allows UBE to address all these pathologies? It works on three very important pillars. First is understanding the bony neural correlative anatomy. Second is important is understanding the underlying UBE physics. And the third most important point is underlying the pathology. So in this high-grade lysis, the pathological part important is that when you have a high-grade lysis, degenerative lysis, the facets are hypertrophied. They lose their normal anatomical structure. So if you do a regular docking and come to the facet and try to see the mountain between, the valley between two mountain view, you won't find it. So that is how you understand the pathology. For that, you have to get a preoperative CT. And after that, you have to modify your docking such that you dock onto a structure which is well known to you and then come to a less known area. And finally, here you can see we were able to identify the disc space and do the decompression and put a large cage. Now, important is that during this process, you have to understand the bony neural correlative anatomy. The important point is that you have to dock along the disc axis, which is called as the disc axis directed docking. Once you do that, all the instruments go in line with the disc. There, you have the benefit of passing your cage directly into the disc. Otherwise, there is a possibility that the cage may be pushed into the body. The second important case, or the application of UBE in a more advanced technique, is when the patient has bilateral symptoms because of a bilateral ventral pathology. So these are very selected patients that we find in our practice, where the patient may have a disc bulge on one side and a disc bulge on the contralateral side also, but not herniated, rather a calcified bulge. What you will do in these cases? Often, in these cases require a work on ipsilateral side first, and then you work from the contralateral side. But applying these UV physics principles along with the bony neural correlative anatomy, we can just remove the whole of the ligamentum flavum en bloc using Z sequence, do the contralateral decompression, and then you can see here we are reflecting the superficial ligamentum flavum that gives the deep ligamentum flavum, doing the complete bony work on the ipsilateral side first. Here, then disconnecting the ligamentum flavum on the ipsilateral side, and So essentially, what happens is you can just go to the contralateral side, and to perform a contralateral discectomy, you can use your same sheath to keep the thecal sac retracted, identify the disc on the contralateral side, and using a forward biopsy forceps, you can do the decompression. That is intradiscal decompression. So that is one of the applications of UBE that you can do when patient present with bilateral symptoms. So this was one of the cases. The patient had not only unilateral disc, but on the contralateral side also there was a significant disc was present. If we can escape the presenter view. Okay, so the next case is, this was an intraoperative surprise for me. It was a usual posterior cervical foraminotomy case where the patient had a C6 radiculopathy, and it was an isolated radiculopathy, and I was like, we can just go and do a foraminotomy and come out. But we did it in the usual process. We identified the V point and then widened the interlaminar window. So this is the V point. That is the important, the most important landmark when we do a posterior cervical foraminotomy, where the V point is the junction between the upper and the lower lamina going to the facet. So once you identify it, then you have to widen the interlaminar window. We follow the feather brush technique of drilling, where we drill the lamina in layer-wise fashion from the cortex to cancellus, then again to the cortex, thin it out completely, and then remove the ligamentum flavum. So we followed this same technique here, and the thin layer of periosteum was present. And this is the white line that we see, which forms the upper limit of the ligamentum flavum. From there onwards, we can simply detach it with the help of a hook dissector. So once detached, you can see that this is the beauty of actually UBE, where some of the anatomy which is not very clear in open surgery, you can see here. So you can see that the ligamentum flavum here is not directly attached to the lamina. Rather, it has a membranous extension that attaches it to the undersurface of the lamina. So once it was detached, then we worked again along the Z sequence, where we detached the ligamentum flavum from all around. First along its top, then came again on the ipsilateral side, and then from the caudal end we decompressed it. So here the superficial ligamentum flavum is detached from the deeper layer. And then we can have this deeper part of the ligamentum flavum. So afterwards, this was also removed. Actually, I wanted to show the main part. What happened was, in this case, it was not that we just had a nerve root. Rather, there was two nerve roots that was arising from it. Yeah, now it's visible. So as you can see here, it was not a single nerve root. Now it's coming or not? Not coming. What happened? Yeah. Some issue with this. I think the previous setting was better. So essentially, it was a case of conjoined nerve root. Yeah, I'll just finish. So it was a case of conjoined nerve root. Now what happens is, with UV, because you have an angled vision and you have angled instruments, you can go around the nerve roots. If it was a single monoportal thing, it is always difficult to have that kind of vision. So that is where UV gives you the benefit of handling these kind of cases as well. Yeah, it's coming. Okay, so then this is the next level of UB, where you can preserve whole of the ligamentum flavum. And once the discectomy is done, the ligamentum flavum can be refracted back onto the traversing nerve root so that it completely covers it and prevents post-operative adhesions. Lastly, for last few months, we have been performing UBE-assisted foramen magnum decompression, where we have changed the docking technique and made it in such a way that you can replicate whatever you are doing in open. The same sequence of events are done with UBE also. So here, we have done the decompression on the ipsilateral side. So this is the lateralmost margin of the thecal sac. We prefer to drill it first and then remove with kerrison. We found that this reduces the chances that it will cause thecal sac injury. So this is the lateralmost part of the thecal sac decompressed. This is the central part of the thecal sac decompressed. And this is the contralateral side, giving a complete 260-degree decompression around the thecal sac at foramen magnum. And on the cranial side also, we can see that the decompression has been done till both the tonsils can be very well seen. So this is again the central part, and this is the ipsilateral part. It goes till the anterior part of the foramen magnum, giving a complete decompression. So this is the midline part, and this is the cerebellum here. So the important is why UBE is a versatile technique is it allows you to expand your horizons. But for that, it is important that you follow three very important principles. That is, understanding the bony neural correlative anatomy, then very importantly, the UBE physics, and lastly, pathological understanding that makes the technique truly expandable. Thank you. And very sorry for the glitch.
We'll take the questions after the sessions, maybe. Now, Dr. Suraj will talk in the revision UBE.
Thank you. I'm Dr. Suras. I've been asked to talk on recurrent UV. My previous speaker, Dr. Vishnu, has mostly covered the topic. For the sake of time, I'll try to rush through my slides. These are my content. So briefly, our introduction. Recurrent discs consist of around 5 to 18% of the patients. Rate of surgical treatment of recurrent discs is around 62%. Revision surgery for recurrent disc herniation is more difficult and has higher rates of complications. UV revision surgery provides pain relief, better pain relief, and earlier functional relief. And with a small incision and less muscle dissection, UV may reduce such wound-related problems. There was a study that is feasibility of recurrent herniated surgery with biportal endoscopic discectomy, a comparative study of bipolar discectomy versus microscopic discectomy for recurrent herniated discs. And the conclusion results where UV revision discectomy had advantages, preserving of the posterior column, contributing to lower immediate postoperative pain. UV group had smaller surgical wound, few wound-related problems and recurrences, but was not statistically significant. Mean bleeding loss and hospital stay was shorter in UV group. Radiation pain showed similar patterns. Incidental durotomy occurred less frequency in UV group and was not statistically significant. Another study like risk factors assessing for the recurrent lumbar disc herniation after unilateral biportal endoscopy, and the study identified that 3 factors mainly: obesity, if the BMI is more than 25, elevated fasting blood glucose more than 5 millimole per liter, and smoking as an independent risk factor. And then they recommended that longer rehabilitation interventions such as wearing a suitable brace and strengthening the paraspinal muscles for patients with obesity and higher fasting blood glucose who underwent UV. So doing these cases, we have to carefully plan these cases. MRI has to be done and CT scan has to be done to delineate the all the bony anatomy. The most important principle is to manipulate soft tissue using bone as a landmark. The safety margin made of bone must be checked using a blunt instrument. In this figure, the dotted one is the safety margin and the black one is a scar tissue. So we will have to know the safety margin by palpating the dotted line. And we can, in one literature, they have showed that the scar tissue can be cut with a surgical blade. And then the safety margin of the bone around the interlaminar space, we then bite with the kerosene sponge, the curate. Dr. Vishnu had talked about this technique, hook and pull method, in which the scar tissue can do with a special probe, we can hook and pull and cut with a cauterization. There is a special hook, RF device. With this device, the adhesive tissue is pulled with a hook and cut by performing electrocautery. Through this method, the adhesive tissue can be removed. This is a pictorial, but it is not very clear. With the RF probe, they are trying to take out the scar tissue. So there are lots of complications as been discussed previously. And I'm going to play these 2 videos. We dock at the facet level. And then we cut the bone. We drill the bone. And then we use a kerosene, we can use a kerosene punch. And then the ligament flavum is there. We can cut the ligament flavum. Yeah. Initially, we dock at the level of the facet. Then we are drilling the bone. We are using the kerosene punch. Then the ligament phloem, we are taking out the ligament phloem with kerosene punch. Then we can see the knob root. With this Indian knife, we are entering the disc space. We can see the knob root medially. Then we are taking out the disc and doing a laminoplasty at the end. This is another video. We are already inside. We are again docking at the facet. Then at the level of the SCP and the lamina, we are drilling it, taking out. It is not clear, a bit blur. Knob root can be seen. We are retracting the knob root. And we are taking out the bone. So to conclude, typical causes of reoperation include post-operative hematoma, incomplete decompression, and recurrent disc herniation. Risk factor including smoking, obesity, diabetes, and surgical factors include larger annular defect and removal of insufficient amount of discs. Biggest advantage of UV is expanded field of view obtained because of the camera. Thank you.
Thank you very much for a nice talk. We will go ahead. Question will be later, okay? Thank you. Who is the next? Dr. Suraj Tulang. Done. So.
Good afternoon, everyone. I would like to thank the organizing committee, Dr. Nikun sir, for giving me this opportunity to be present here. And when I reached up Nikun sir, I asked him, sir, what topic you want me to present? And I just suggested him a routine topic. He said, no, I have a special topic for you. I'll give you a topic that is very close to my heart. So he said, why don't you talk on a butterfly challenge? It's an egoistic maneuver or a necessary one. I said, sir, this topic and the title is a bit harsh. He said, no, don't worry. So I have taken up this challenge, but whatever I'll speak, I'll try to balance and I'll try to speak in a scientific manner only, whatever I'll speak. Thank you, and one and all. So, where is the butterfly? So all of us know that the phloem has its attachment cranially and caudally, and its cranial extension goes laterally to form a butterfly. It has 4 attachments: cranial lamina, caudal lamina, laterally to supralaterally to SAP, and in the midline the 2 halves join each other. So till now the conventional thinking has always been first expose the dura, and then see the phloem, make a plane, and then do a piecemeal removal of the phlegm and decompress the cord. But the butterfly thinking is first we do the bone work and then we create a plane between phlegm and the bone. We preserve the phlegm and prevent any unnecessary expansion of the cord, and then we remove the phlegm. So phlegm becomes a protective layer for us rather than an obstacle. So why is this necessary to preserve the layer? Because it acts as a shield. First, it prevents any undue handling or manipulation of the thecal sac. It also keeps your field clear, because if the phlegm is open once a while, some epidural bleeding will come and your screen will all be red. So it keeps your field clean, which definitely helps you in getting your job done. And it keeps the things in control. It delays the dural expansion, which in turn has been found to cause dural tear. Because after you have removed the phlegm, there is expansion of the dura and you tend to catch up that dura into your kerison. So what is this en bloc, which is why the en bloc thing is becoming so much of a noise? Because there's some term called as kerison addiction. All of us are very impatient once we see the phlegm and will tend to bite and remove it in piecemeal. So fewer kerison bites, fewer kerison manipulation before any dural exposure, that prevents any undue bleeding and undue traction on the dura and prevent any complication. As I told earlier, it acts as a shield, less dural expansion and a cleaner field. This logic seems reasonable, it's plausible, but is it actually better? So en bloc flavectomy has been described earlier also in microscopic decompression cases, but its role has been discussed previously only in terms of pain relief, adequate decompression, but it has never been compared with other techniques like piecemeal techniques. But recently in 2023, Tumialan has published a paper with 147 cases. This was a microscopic decompression. It was not a UB decompression. And after that, in recently 24-25, UB decompression and UB en bloc phlegm removal papers have started coming in. So the concept of en bloc removal is older, but for newbie is a recent one. So the paper which I was talking about, the microscopic decompression by Tumialan, what he says is he has said that at one level, let's say L3-4, the canal is more wider at the cranial level and it is narrower at the caudal level, where the phlegm attaches to the caudal lamina. So whenever you are trying to dissect or you are trying to detach the phleval attachment at the caudal level, you tend to pinch or you tend to grab hold of the dura, and there it is most possible that you might injure the dura or you might tear open the dura. So he devised a paper where en bloc resection of phlegm with laminotomy of the caudal lamina. So beyond the attachment of the phlegm, he has done a laminotomy so that the caudal attachment gets free and it can easily be removed. So he did a comparison between two piecemeal and en bloc. 77 cases of piecemeal, 70 cases of en bloc, and 5 CSF leaks he saw in piecemeal. So like I said, because it's a very narrow corridor where it attaches at the caudal level, this was definitely found to be, en bloc was found to be definitively a better technique. So the principle, anatomical principle is supportive, but it is not a universal superiority. So then comes the UB butterfly technique. It was published initially by my mentor, Professor Park Chul Wong. In his paper, he has devised this technique of U-shaped removal. First ipsilateral laminotomy, then you go sublaminar contralateral side, you detach it from the opposite side, then you come to the J point, L point, you detach it below, and then inferior lamina, and you remove it as a whole. There's another paper of UB decompression, which was published by Lee et al. In 2024. This was done for interbody fusion cases. He did en-bloc flavectomy in 51 cases and piecemeal in 58 cases. There was a significant difference in completion with dural tears. 3 cases seen 5% in piecemeal and 0 cases in en-bloc. Although the clinical outcome of this paper was the fusion, so it was similar in both cases, but the complication rates were found to be more in the case where the piecemeal decompression was done. There's another study by Arian Can where another technique was described, which is a two-half technique or two wings technique. So he described, he compared all 3 techniques: piecemeal technique, en-bloc technique, and the open book two halves technique. So in that he found that comparable numbers in each group were there, and the complication rates were found to be more in piecemeal technique. And also it was found that the two-wing technique is significantly shorter, with a 45% surgical time reduced as compared to piecemeal, and 30% reduction in time as compared to the en-bloc technique. So maybe the perfect butterfly is not the point. Whether you remove a perfect butterfly or not is not a point. The point is that if the anatomy is favorable, you can remove a butterfly. It's feasible. But if the anatomy is not favorable, you can as well remove it in 2 halves, which is also a reasonable compromise. So when would I not force a butterfly? So what is the unfavorable anatomy for me? When there is adhesion, it's a revision surgery, there is no scar formation, or there is no interface between the flavum and the dura. The flavum looks calcified, it might be stuck, the dura also might be calcified or stuck to the flavum. And when there is critical stenosis, when the mobilization of the flap is difficult, and one more point, the patience of the surgeon is utmost important, because like I said, the Carrison addiction, if it's there, it's difficult for the surgeon, because it'll keep on pushing you to just go and bite a piece. So the technique should adapt to the anatomy, not the anatomy the other way around. So according to the Shizar's grade, how tight is the canal? So does the canal size affect your decision? No. The canal size, as well as whether the other factors are also favorable, you can go ahead with the butterfly. So Shizar's grade B, the rootlets and sac remain individually visible, you can go ahead. It's a butterfly territory. In category C, there is no visible CSF. The rootlets are not separate, but there is a posterior epidural fat is visible. Butterfly is still attractive. But in critical stenosis in type D, you can still do it, but you have to be patient, and the flavum is traction sensitive to you. If it's not possible, you can always divide it into half and take it in 2 pieces. So the Shizar's grade grades the dural sac. It does not grade the ligamentum flavum and dural plane or calcification or any decreased mobility. So my practical butterfly decision algorithm is, when can you go ahead and take out a butterfly, is first see the MRI, how severe is the canal stenosis, whether it's B, C or D. Step 2, you see the anatomy. Once you've gone inside, see how the planes are, is it stuck anywhere, whether you have detached the flavum all around before pulling it, and whether it's ossified or not. And step 3 is operative feel. How comfortable are you to turn around it in one piece? Because when the canal is narrow and you have to take out in a single piece, the turning it up to dissect it from the dural surface, it's really a patient job. So the goal is not to win against the flavum, the goal is to decompress without making dura part of the flavum. So there is no validated Shizar's cutoff for butterfly feasibility. It depends on the grade of the canal stenosis, anatomy, once you have inside, anatomy of the flavum, and surgeon's preference or his skill levels. So in real-time comparison, piecemeal removal will remove the protective layer of the flavum pretty early, and it will have more manipulation, making it a technically lower demanding and a more risky job. Rather, a butterfly or two wings technique is more feasible and more safer. So my answer to the title, whether it's an egoistic manure or a necessary manure, I would say no, it's none of them. It's not necessary. There is no evidence that it is the universal superiority. You have to remove in en bloc in every stenosis. And it's not ego, because it does prevent and acts as a protective layer and reduces repeated manipulation. So it has a rationale behind it. And if used properly, it can be selectively used in cases which you feel you are comfortable to remove it. So butterfly is a strategy, it's not a religion. So not all cases are butterfly cases. So 5 rules for the OR: find your plane before you pull, bone first, dura later, outside in technique, respect the lateral attachment, do not pull till you have dissected and detached phloem from all sides. If one piece is fighting you, please make 2 wings. The goal is decompression, not the specimen photography. And rule 6, never let the ligamentum phloem know that you are emotionally attached. If he knows that you are attached to it, it will definitely give you trouble. So the take-home message is the butterfly is not the goal, safe and complete decompression is. En bloc flavectomy is a rational technique with promising safety signals, but the current evidence does not establish a universal superiority. It definitely is a good procedure. So beautiful butterfly, boring decompression, happy patient. You have to have patience if you want a butterfly. This was a butterfly. Never celebrate too early. Thank you.
Thank you, Dr. Rohit. You did more than justice to this presentation, actually. Thank you. We are not taking any questions because we are very, very much late. I think we'll directly jump into.
Thank you so much, Doctor. May I now request Dr. Amol Regi, sir, to present the token of love as a gesture of appreciation and gratitude to our esteemed speaker. To receive the token of love and a certificate, I would like to welcome our speakers. Dr. Ashutosh Kumar, Dr. Bishnu Babu Thapa, Dr. Suraj Tulung, Dr. Jitendra Thakur, Dr. Rohit Wadikhaya, Now I would like to welcome our moderator panelists to receive the token of love, Dr. Rasujon Rakhimov. Dr. Prakash Kafle, Dr. Nikunja Yogi, Dr. Suraj Tulung, Now I would like to welcome all the speakers and the moderator panelists for the photo session. Dr. Ashutosh Kumar, Dr. Jitendra Thakur, Dr. Rohit, Dr. Vishnu Bahadur Thapa, I would like to take the opportunity to sincerely thank all the participants for valuable time, active involvement, and enthusiastic participation in the session.
Thank you for being such attentive and wonderful audience. I hope you found this session more informative and useful. We would like to move forward with our next session on the topic, the UBE journey. Let's welcome our moderator panelist, Dr. Chandra Prakash Limbu, Senior Consultant, Neurosurgeon and Endoscopic Spine Surgeon at Annapurna Neurological Institute and Allied Science.
Dr. Rajiv Pandit, Consultant Neurosurgeon, Annapurna Neuro Hospital, Kathmandu, Nepal.
Dr. Somraj Lamichhane, Consultant Neurosurgeon, Scientific Committee Member, ISUBE SSEA.
Dr. Pankaj Raj Nepal, Consultant Neurosurgeon, Arya Neuro Hospital, Biratnagar, Nepal. Dr. Chandra Prakash Limbu, Senior Consultant Neurosurgeon and Endoscopic Spine Surgeon at Annapurna Neurological Institute and Allied Science. Dr. Pankaj Raj Nepal, Consultant Neurosurgeon at Arya Neuro Hospital, Biratnagar, Nepal.
Okay, so let's start the session. So first speaker of this session is Dr. Prakash Kafle on UV in lumbar spine surgery from learning curve to clinical practice.
Hello and good evening. I bring you a warm welcome from Nobel Medical College Teaching Hospital, Biratnagar. Next 10 minutes, I'll be talking about the UV, how we involve into the UV surgery and how the involvement could be brought into the clinical practice. This presentation is basically targeted to the younger generation who are interested or who have been establishing to do the UV surgery. There is no conflict of interest to be declared. So before starting the topic, I would like to acknowledge my mentors and the two institute. This is Tiruvana University Teaching Hospital, where I got the this basic my training, and this is the medical college at Nobel Medical College, Viratnagar, where I do the current practice. And he is Professor Mohanraj Sharma, the current Dean of TUTH at Tiruvana University Teaching Hospital, and he is Professor Sushil Krishna Silpakar, my mentor, teacher, who was the then HOD of the department, and he is Dr. Gopal Sedai, Professor of Neurosurgery and head of the department. And he is Professor Siolung Park, who is a pioneer of UB spine surgery, under whom I got the training of UB, and he is Professor He is my friend, Professor Edmond, who pushed me for the UB surgery. So if you see these two images on right and left, one of the mountain, another of the stepwise pattern, how you reach from the base to the summit. So when you plan to climb a height or attain something, you should always be careful about the possible hazards or the challenges that can be anticipated. That is how you will prepare. As in climbing, you should make habit or develop stamina to climb. In such a way, in medical field also, at the base camp, you should start attending the conference, going to the labs, and in second stage, you have to go to and work under the seniors. And in the third stage, you yourself practice independently, do the small uncomplicated cases. And in the third stages, or in the advanced stage, in the red area, where the summit is, you do the advanced cases or complicated cases, then you develop the mastery. Before starting UB surgery, you should always realize that no matter how good or bad you are today, you should accept and go ahead thinking that every expert was once a beginner. This is how you can start. So talking about the background and evolution, I need not to spend time on this slide, as we are all known about this and we have been discussing about the same thing from morning. So next horizon is robotic surgery. So what is UB and why UB is at present? It's already told that many of these speakers have already highlighted on this thing. So it is always a biportal system with camera and working port. Facility of continuous saline irrigation provides, water medium provides more vigilant, and there is a bimanual surgical handling, so the movement and maneuver will be easy. So why UB and why now? It's because the bimanual handling reduces the blood loss and it also decreases the muscle trauma. It minimizes post-operative pain, faster recovery, hospital stay, and cost as well. So why now UB to start? It's because if you go to many centers, there is always expectation. Do you do spine surgery by a hole or a durbin or whatever? So patient's perception has changed. So why not the surgeon's perception should change? So our mindset should change. But the question is not, can I do it? The question is, can my system do it safely, repeatedly, and in the auditable way? It can, like endoscopic spine surgery can be done by UB, uniportal or biportal. I am practicing biportal, but uniportal is equally good. The only one disadvantage with biportal is you have little bit of tissue injury. You have two holes. Otherwise, other things are almost equal. And in uniportal, you'll have little bit of this pain because of longer instrument. The basic concept is, one is viewing portal, in which we use endoscope, continuous irrigation, and panoramic illumination. Another is a working port, in which we use the conventional instrument, what we use in the regular open or microscopic surgery, except RF probe. And the facility of this water, which acts as a third assistant, it maintains the view, it tamponates the small vessels or venous ooze. The UV does not replace anatomy, it magnifies the consequences if not respecting it. So how did I begin my UV journey? Just I want to share it. The first lesson, when I went to Korea, I did not learn how to do UV surgery. The first thing what Professor Park taught me was, in UV surgery, surgeon must learn to see again. Our mindset is with a naked eye or with the microscopic view. Now we have to change the viewing idea, hand-eye coordination. So scope teaches the patience, bleeding teaches you the respect, and the time pressure teaches the preparation, and the difficult cases teaches you the boundaries and your limitation. So learning curve is not a slogan, it's a risk period. If you see the paper published by Sushin Liu et al., the team has nicely meta-analyzed the studies. How long does it take for you to become an expert? In this, what they have come to the conclusion is that if you want to be an expert, you should have done at least 35 to 37 cases. But it depends upon the exposure, the types of cases, and your interest. So you should have done at least 37 cases to be an expert. So in the first 10 cases, it's just a survival period where you get orientation, portal handling, and you will learn how to control the bleeding. That is the red zone area for you. And the next is yellow zone area, in which you do 10 to 30 cases. In this, you will recognize the pattern and which cases to choose and which cases not to choose, or what is your limitation. It's because for surgeon, choosing the case and your decision is the first instrument in the tray. So don't think that you have a UB said you can do everything. So after having done 30 cases, then only the green area starts, where you become experts and you can do the multi-level cases or complicated cases. So to come to this green area, first you should make your base from this green area, like you should do uncomplicated cases, non-scarring, with no instability or non-migrated cases. Then you go to the yellow area, then yellow cases that you do foraminal stenosis or decompression multi-level cases. And once you develop the confidence on that, having done 30 cases, then you go to the risk area or other competent, which requires more competency, like severe cases with instability, defense scarring with a major deformity, or migrated disease. So this is just a OR setup. How can we do the, for beginners, how to put the drill system, monitor, surgeons, assistant. These are all shown in the pictures. We can see later on. So how to start UB? For the beginner, you can go to the this conference or listen this thing and learn. And this is the standard steps. So positioning, triangulation is one of the most important. If you have done angulation pre or post, then you will be lost. Your one instrument, this light source, should be always guiding to the working instrument. So your target will be like this. When you are showing this light through this, if you are right-handed, if you are showing the light source through the left, then your right will be the operating end. So your target will be always your light source should show the operating instrument, so that instrument will not fight. So this is how you position the patient, so as to prevent the abdominal compartment pressure to come down, and the pressure point should be well taken care. So this is the marking, the medial pedicular line. Everybody is talking about this. This is the video, how we do the drilling and create the potential space. It's because there is no any space, so-called space, that is where we create the space by coagulating these multifeeders and create this space. So that is very challenging. So this is the video from Professor Park, where every step has been shown. Because of time constraint, I cannot show this whole video here. So whenever you do this UB, don't feel that conversion is not your failure. You have to convert the cases when anatomy is not safe or orientation is lost, bleeding is not controllable after systemic steps, dural tear requires better access, or decompression ends point is uncertain for you, or the equipment or visualization fails. So the goal is not to complete the UB. The goal is to complete safe decompression. So put your ego down, convert the case into open, it will not harm. So patient safety is the number one. So these are the representative cases where there is a lateral foraminal disc, and this is the post-operative image after decompression, and the migrated disc has been taken care of. So where we are in the literature regarding UB, though this lumbar microdiscectomy is the standard care, but now UB is in the rise. There is no any level 1 evidence which has compared UB versus or microlumbar discectomy to claim it as a gold standard treatment, but think that endoscopic spine surgery will come and it is going to be the standard. So what the evidence supports and what it does not is, what is consistent is VASI score and ODI improves after UB. Decompression can be adequate when technique is standardized. And what is promising is less soft tissue injury. What remains uncertain is comparative superiority is not universal, selection bias and surgeon experience is equivalent vary. So what about UB in Nepal? Dr. Nikunj has already told and he will be telling, so I'm not going in detail about it. So the day I was almost given up is, it was a simple L45 left-sided disc. I started, it took me around 7 hours and I was tired and I was thinking, shall I leave it? It's a real. But on the next case, I questioned whether I had brought a technique home too early. Then the next case was planned, it went better and I did not break my learning curve. So the curve did not disappear and I still kept up maintaining the learning curves. So don't give up because it is hard, give up only if you stop making it safe. So the take-home message is UB is powerful corridor, but anatomy remains the truth. The learning curve is predictable, so it must be managed. Case selection is patient safety, not surgeon's limitation. Conversion is wisdom when the endpoint becomes uncertain. So we from Nepal can build UB this responsibly through training, teams and registry data. So what I realized during this journey is difficult road often leads to beautiful destination. The best is yet to come. So the journey of thousands miles begins from the first step. So thank you.
Thank you, Dr. Prakash Kafle, for wonderfully explaining the learning curve in early phases of UB career. So we are running out of time, so we'll take the question at the end of the session. So the next speaker is Mohammad Asad Javed, learning curve in UB, avoiding early complications and building confidence.
Good afternoon, everyone. It's the end sessions and everything has been discussed in very detail. I think, as far as I'm concerned, UV is an addiction. Once you get used to it, you will not be having that fun while doing any other open surgeries. So we'll try to do every surgery through UV. So that's my story of UV learning and then the learning curve. I'm working as a consultant neurosurgeon in Akbar Niazi Teaching Hospital, Islamabad. And I'm honored that I have learned UV from Nepal. And just when I went back to my own country, I started doing UV cases. And now I have touched 200 cases almost. So I will discuss about my own learning curve. First of all, I would like to thank my mentor, Dr. Nikunj. That's where I started. And that's the day when I learned the first UVE endoscopic disc surgery from Dr. Nikunj. And that there was the day when I thought that why I was doing the open surgery or microscopic surgery. Because of different reasons. Because when you go in, you see the vision, everything is so much clear that you will not see this kind of clarity in open surgeries. So why we want to discuss this learning curve? You know, the thing is getting boom, everyone is trying to learn this UV thing, and in our areas, South and Southeast Asia, we have now, alhamdulillah, created a society, and a lot of our colleagues from Pakistan, they're also inspired by the UB surgery, and they're taking keen interest. That's why a couple of my colleagues are here. So I think it's better to understand the learning curve. So complications, basically, they occur while you are in the start of your career of UB. So if you have that, the knowledge of the basic anatomy and you know how to avoid those complications, then you will go smoothly through your learning curve, and then you will get into the stage of competency where you can do every pathology via UVA. So in this presentation, we will go through this learning curve objectives, and we will understand that what are the common complications which you experience while doing the UBE, how can we understand their pathology, and how can we avoid them. First of all, the historical development. This thing is basically inspired by the arthroscopy. I think the guys saw that when we were doing the knee arthroscopy, there is a closed cavity, and you go in and you can do the surgery. This can be done in the spine as well. So the first endoscopic bipartite surgery was being done in 1996. After that, it got down, and then it again reappeared and taken that huge success right from 2011 and onwards. So now there are a number of things which we can deal with this UBE. Dr. Amit Thapa has had a wonderful presentation on that, and a lot of other colleagues who had presentation about the UBE, different pathologies which are being done, which are being dealt with this UBE thing. So what are the advantages? If we see the UBE, how it's different, because when you go in, you see that your visualization, it's excellent visualization. You can even see the RBCs. One of my colleagues was saying initially that you can see the RBCs under the scope. So that's make you an addictive to that UV thing. And you have those specific instrument which were you using initially for the open surgeries. So this is not a, I would say, not a surgical instrument dependent surgery. So you can use those open surgery instruments. That's why that's easy to understand and start with the UB. And there is also preservation of the posterior structures. So what is a learning curve? For me, learning curve is the number of cases, how much cases you do before that, after that you become so competent that your results, your operation time and your complication rates come at a stable rate. So for that, there are different analysis, mathematical, statistical methods through which we can analyze ourselves, whether we are improving with day by day or we are regressing. So there is cumulative sum analysis, RACU sum analysis, operative time trends, and complication trends. How many cases are needed? It's, I think, different for different persons. If one is doing open or tubular surgeries before that, it's very short for those surgeons who are already exposed to the spine surgeries. And they are using endoscopic things before the UB. So there are different studies who have their conclusion that different cases which are required to become a master of the UB, at least you become so efficient, you can have a reproducible results in each case. So the basic competency, for basic competency, you have 30 to 50 cases, and for complication stabilization, you can have 38 to 50 to 90 cases, and advanced surgery mastery, where you will start doing the fusion surgeries, going to the thoracic level, and the cervical level is more than 100 cases. So what are the early complications we mostly see during the learning curve? One of the feared complications is the dural tear. I have an experience of, very bad experience of having dural tears in my initial cases. And yesterday when Dr. Hu was putting those K wires directly on the lamina, that reminded me of my few early cases where I get into the dura, and when I landed in and saw the noodles were coming out. So anyhow, that's a very feared complication. So if we see what is the approximately 1 to 5% chances of having this dural tear. So what can be the causes of the dural tear? One of the things which I told you earlier, that if you get in with the direct K-wire needle, you can go in, puncture in the dura, and you can have those dural tears. Second is when you go in and you do aggressive flavectomy with, you use aggressive radiofrequency ablators with a ablation mode, you can just puncture in and go into the dura. The other one is flavectomy. Once a surgeon sees the flavum, the yellow thing, he can't resist to take it out. So it's a game of patience. So when you see, you have to be patient to remove the flavum. While doing flavectomy, most of the dural tears occur while you're removing the flavum. So how can we avoid them? And the other thing where you can have the dural tear is the bleeding problem. Once your vision is not clear, there are chances that you will take the dura and you will take the injure the dura. So how to prevent this kind of injuries? Always read your MRI first, read the anatomy of the patient, and then when you are going in, always follow the baselines, which we have been taught by our mentors. In the beginning stage, it's better to follow each and every step for marking the spinous process mid-IV line, which have been told, and do a perfect triangulation. Later on, once you go in and when you are taking out the flavum, always my teacher used to tell me that you lift up the flavum and then cut it, not pull it. So that's a good technique to avoid this dural tear. And maintain a clear visual field. Once, if it's bleeding, you try to just clean it up. Either you have to check the blood pressure, or you have to you have to increase irrigation pressure to decrease the bleeding. You can use the RF to slow down the bleeding. So the other thing is epidural hematoma. Thanks God I didn't have the experience of this kind of thing. Majority of the time I keep the blood pressure low, around at 100 systolic, and I also give tranexamic acid during the surgery. So there is less chances of hematoma, but I guess you have to individualize each patient because sometimes patients are old age and they are taking antiplatelets. You have to take a proper history and you have to stop those anticoagulants before going for surgery. And intraoperatively, if you see some bleeding, you have to control it with the help of bipolar RF coagulator, or you can use the bone wax on the bleeding if it's bleeding occur from the bone. So most hematoma usually occur during the first 50 cases. So then comes the incomplete decompression. That's the thing which is, I mean, if you don't know the anatomy, and endoscopic anatomy is a bit different from the open one. So if you don't know the endoscopic anatomy, there are chances that you will not properly decompress the thecal sac and the exiting and the transversing nerve root. So to avoid this kind of thing, you have to follow the checkpoints. Whenever you are going for a severe renal stenosis, you have to start from the superior lamina to the contra lamina, then the caudal lamina, and both of the exiting nerve roots, so transverse nerve roots. So if you check all these points and they are free and there is no tension on the nerve roots, of course you have done the decompression. But you have to follow a pathway. Always look for the neural tissue, whether they are under tension or you have released all the pressure points. Now come the visualization and bleeding problem. At times, if you have, you are holding the scope and accidentally you can injure it with your RF or drill, you can have problem in visualization. Before doing a surgery, you have to correct the magnification of that, your endoscope, and if there is some kind of bleeding which is coming from the, which can come from the skin incision, from the muscles. So you have to look for the bleeding and to stop it to have a clear vision to avoid other complications. So for beginners, I would say that single level disc herniation, probably L5S1 on the left side, is a case of choice to go for the surgery, and they must avoid severe canal stenosis, bilateral decompression. Fusion cases, of course, they should start after 100 and if you an obese patient. So my message is how we can shorten this learning curve. So first of all, I would say that you must find a mentor which would teach you the basics of the science and the art of this UB. If you come and you see, if these things are available on YouTube, you can see it, but you can't be like, you have to go to someone, you have to learn the basic points. So mentorship is the thing which, for the beginners, I would say that they must find a mentor which teaches them how to do the thing. And once they are used to it, they can be a mentor one day. And the other thing which I found is cadaveric workshop. When I was here, I did so much surgeries on the cadavers that when I went to the operation theater, it was very easy for me to understand the anatomy, and then I can do it easily. So these two things are most important to shorten this learning curve. And again, use of 0-degree scope is, I think it's beneficial for the beginners as compared to the 30-degree scope. Proposed stepwise UB training program, I think in phase 1 to 20 cases should be simple lumbar disc herniation. You have to do portal basement and instrument handling. It would be in this phase. Phase 2 will need bilateral decompression and contralateral decompression. In phase 3, when you have reached 50 to 100 cases, you can go for the complex stenosis and multi-level decompression. And if we have crossed 100 numbers, you can go for the T-lift, revenge surgeries, and even you can start with the thoracic and the cervical surgeries. So the take-home message for this is learning curve facts. This competency requires at least 30 to 50 cases, and stable complication profile may require 50 to 100 cases. So most complications are preventable if we follow those guidelines which are already been told again and again. So proper patient selection, cadaveric training, having a mentor in your life is very easy, because I remember the one I used to call my mentor before my cases, even at 11 o'clock in the night. He used to tell me how to proceed. And thank you very much, Dr. Nikunj, that I'm here today, and I'm crossing those numbers because of you. Now, hopefully, we'll start with the cervical and the thoracic and the fusion surgeries. Okay, that's a smile which one gets when your students do the first surgery, and the mentors is so happy you can just guess. It makes so much happy. So I'm thankful, very thankful to you. So these are another case. I would like to say that just going to your mentor and learning from the mentor is not enough. You have to teach this knowledge to others. That's how you become more, knowledgeable. By sharing knowledge, by telling other people that how to do things, I think one learns from this. More learns from this as compared to just doing the thing. So my mentor again pushed me to do these things. I have done 5 courses, and many surgeons from different parts of Pakistan, my colleagues, my seniors, they come to me. I have live demonstrations of the cases, and many of them then started their surgeries. They are doing UBs. So I will want to show this. This is the first one where I have 5 different neurosurgeons from different areas of Pakistan who came to me, and we had this demonstration cases. So I think once sharing your knowledge is very important. That's how a person, and that's the other one where I'm demonstrating a case to a surgeon colleague how to, and that's few of my colleagues are sitting here. That was the case we had done at night, and after that they also started the UV. This is my friend, this is my senior colleague. He's working in UK in Manchester in a spinal unit. He came to me for this UVA thing. So I also demonstrated a few leg cases, and that was the recurrent disc surgery case. And these are the 2 other guys. They are not here, but they are planning to come here to Dr. Nikunj and learn more. This is the very proud moment for me that one of my teacher, he's a professor of neurosurgery who's standing right here. He came to me that I want to see this surgery, I want to do it. So I'm demonstrating that right-sided disc surgery to him. And that was a wonderful moment for me, because once a teacher who used to teach you something, he comes to you and now I'm teaching him something. It's a proud moment for me. And hopefully in the future, with the help of my mentor, I would going to start a UB course in Islamabad, Pakistan. And my colleagues are here. They will also participate in it. And my Professor Saab is also here. Hopefully, inshallah, we will take this technology, this art and science of UB to our country, and we'll spread it like our mentor is spreading it here. I will not forget Nepal. It's very, lovely country. People are very down to earth. We like the environment, and the Milan, sir, is too good. And they are providing us everything. Thank you very much for the time and your patience. Thank you. Any question, please?
I think there is no questions. And we are short of time. So thank you for a nice presentation, Dr. Asad. I would like to welcome our next presenter, Dr. Ramesh Sigakoli. And the topic is UBE, a paradigm shift from open surgery to precision minimal SS spine surgery.
Very good evening. With the outset, thanks Dr. Nikunj for the opportunity and the ISUBE SSEA chapter. So I'm on and out. I'm more of a cranial neuroendoscopic surgeon. Very interesting into ETV, translaminar terminalis, transaqueductal. Then one day, Dr. Bala from Hyderabad has called, come on Ramesh, we have a new procedure. Why don't you see? Then I was fascinated. Okay, we should do. My only thing was being a cranial neuroendoscopy skull base. So you have a hand-eye coordination. Anyway, you know the anatomy, so you should start. That was our intent. But when we want to start, the problem is instruments. I went to management and asked needed instruments. So he said, you have GAB, you have mini GAB, you have ASCLAB, you have skull-based set. I'm not going to give another spine set, so you manage yourself. So you're not going to Korea, you're not going to China. So now how about to go about? So I'm trying to present, as I thought initially, present these current concepts. But when I sat down and writing or doing a presentation, I thought we'll present our journey, how did we start and how did we do. So it will be very helpful for the beginners. Coming to the presentation, how many people have read this book? We don't read, but we follow our life. The problem is in the mind than the problems. So if you think that's a religious book, then this book at least. So these are the solutions to our life. For example, how this one is a newly introduced to India. Can you write this? That's Tesla. So can you write this vehicle without reading the manual before you are not read? In the same way, whatever you do has to you understand the biophysics or mechanics to do. So the same disc we have been trained during your residency of laminectomy, hemilaminectomy, gold standard of microscopic tubular, and the destandio endoscopic. So now how to go about? It's a fascinating thing. So looking at the same disc in a different way. So this slide actually fascinated us to look at the opposite side through endoscopy, which is not possible through destandio. So difficult to learn and practice, which was not trained during your residency. But this has extended his indication, so you have to learn. That's the survival of the fittest. So then we'll show what's our journey. We reached the hospital. They say, we wanted to start UB. No. So orthopedic has a RF. So we reached him. He said, you can use, but after my cases list. So then, okay, thank you, at least you told okay. Then we started begging anesthetists to work extra time. Arey, come on man, don't take 4 o'clock case, including scrub nurse. So she don't want to spend time. You're not paying me extra. So, but they all helped us, that eventually we are standing here. So what was the common fear at that time? The fear of failure. And you have to run, because there is no system. You have to finish in a 1 hour, or 2 hours, or else you have to open again spend 1 hour. So that was the fear behind. And chances of complications are also high in the initial stages. So nobody understands the surgeon there. So everybody wants to run home. And if something goes wrong, it's a legal issue. Basic disc, you added foot drop. So fearing, slowly doing things. So first to understand how to do the anatomy of the operating room. Then I'll just show you what we learned over the time. Always do a patient position appropriate. What usually ask the DNB resident or the MCS resident to position and clean, I will be coming. So always stand there, break the table, because a millimeter can also help your life, make your life comfortable. Then always do not forget to square image, because we initially burnt our hands, we are lost there. What was the mistake? We gone back and read that the squaring was lost. So these are all standard technique, but you see, if you can appreciate, there is a needle here and there is a needle here. Because we lost to the next level or the above level in 2 cases, then we developed that if keeping one needle helps us till the triangulation, till the disc space, so why can't we decrease the shoot? And also if in overweight patients, just take a lateral and lateral so that your triangulation is easy. And also these steps I'll skip. That's what I was trying to tell, the needle in the disc margin. You can see here, and okay. So always do triangulation on the CM, always and always confirm every step under the CM. If it's very too acute, instruments will collide. If you are too obtuse, your tools will not reach the target. So when we reached Dr. Nakuj, he said, better to found the elephant than a mouse. That helped a lot. We were struggling with to get a triangulation. When we kept a RF, when we kept a sheath, then we can found it easily. So that was very difficult at first time. Then it slowly came down. What is the rule we followed was, if you feel instruments are straining or feeling wrong, do not force them, try them. So if not, so completely withdraw to rule and again re-triangulate. That is more safer. So that's how, around 30 to 45 degrees the angle, not too close, not too far apart. So slowly we learn triangulation. We learned triangulation, that was the biggest, I throw a party to our colleagues, we have done a triangulation today. To that stage too, we have done a needle triangulation also. So slowly we have learned over the time what to do and how to do. So this step will definitely help us to decrease the muscle coming down intermittently. And this is a fascinating screen. So this screen for a cranial neuroendoscope is a nightmare, where you do a ETV or you do a choroidal plexus tumor or do a transaqueductal, but that just became normal in initial days. So every time when you see a red screen, it is not just always due to bleed. So it can be adhesion. You see, over the time, I have not done anything, but you can migrate. So my triangulation was not appropriate. So again, went back, did triangulation appropriately. So if it is a really bleeding, then you increase the saline flow, check the outflow portal, back out and again advance. If it is a bleeding, then you use the hemostasis with the RF or the things you have. So this was another challenge, whether to use the pump or use a height. When we used our height, it was not opening. Then you have to use the pump. Initial 10 cases we used the pump. But if you exceed the high pressure, it can lead to dangerous ICP or neck pain post-operatively. Or if you use very low pressure, the working space gets collapsed as it is a potential space. The golden rule is to keep lowest possible pressure and also the lowest possible to keep your field clear. And these are the sheath retractors with three. So that will help especially in the obese and large muscle group, in the paraspinal muscles, to not interfere in our working field. And also one very important thing in initial days, cut the fascia cruciately and more so that the inadequate space will become blindness. Facial incision should be wider than your skin incision. This will help that the intramuscular spread of fluid is less. And if you don't do that, that swelling of the muscle will happen and slowly spread up. Orient your anatomy to the team, especially when you are starting. Bone dust clearing, very important. You can see. See, I was in a hurry. I was not worried. We didn't have a hooded drill. We used a transpinodal drill, what to drill. So slowly, I did not clear the soft tissue also. Because whenever we introduce for second time, third time, when our initial triangulations was not appropriate, so I don't want to go inside and come out. So I have not used, if you see in my initial videos, most of the soft tissue is around that. I was trying to push the line so that the soft tissue which are detached will come out. So that I don't want to keep my disc forceps again come out, then again the triangulation goes away. It will take another 10 minutes for me to settle down. So as I already explained, the superficial layer should be done so that you get the space and go along that attachment. You can see. So I was hurry to attack the disc as early as possible. Ligamentum is not excised and all the free fragments are also not removed because the lack of time. 7 is happening, they wanted to close, they are not going to give. So slowly over your time, now we have done around 50 to 60 cases. So that was beautifully explained by our, and the sheath. This was not there. So how to retract was the major issue. So slowly we bought that scope retractor. Nowadays we do a good decompression both ipsilaterally and contralaterally. Then at least 50 to 60 cases. It's a similar thing. Showing the contralateral disc and the root. This was the dreadful complication, dural tear. I had 2 times dural tear and 2 times invariably I opened. I was not, why? Because it was always in the mind, fluid will ingress in through this space, through the open dura So always lower the irrigation, immediately apply the closure mechanisms if required. Then don't hesitate, convert to a microscopic repair. And then always look at the time. Don't worry, take your team into the confidence, and don't shy to convert whenever you want into open. So this is one of the example. This is extruded disc. That was the ligamentum flavum, but during I want to close it out, but I was thinking the extruded part is not coming. When we went back and next day and watching our video, I understood that at that time I was thinking it's extruded disc that's not coming. So, but actually it's a ligamentum flavum which was not detached. You can see the fragments were not removed because I don't want to go in and go out, so the triangulation may go away. From that level to, so everything was clear. So that's a, again, this is a very important point. When you do a right-sided disc, it is very, very difficult. Slowly spend time, you will get adapted. As Dr. Nikun says, change your ports so that you are more adapted. And especially, I was worried to do extruded disc, but I say extruded disc actually have already created a natural corridor for you. So you see here, this extruded disc has created a corridor, and the root and the thecal sac is pushed to the medial side. So easy to pull it out. So we have done initially around 50 to 60 cases. Thank you. Take home message is have a grit to learn and patience during journey. Spend time in triangulation. Never hesitate to ask for help. Analyze your videos after surgery. If your basic decompression dissection is achieved, then expand indications. Thanks.
Thank you, Dr. Ramesh. The next presenter would be Rohit Kaviswar. The topic is adolescence lumbar disc hernias.
Good evening, everybody. Thank you, Dr. Nikun sir and team for letting me present our work. I'll be speaking on adolescent lumbar disc herniation, a glimpse into the future of pediatric spine surgery. So as rightly mentioned by Dr. Javed in his previous talk, you need to have mentors and good mentors, and you should yourself be convinced first that the technique is superior. And one of my first mentor was Dr. Wu in Singapore. I was with him for 1 year. So my first case with him, there was a guy from Sweden. He operated in the morning, and evening when we went for round, he asked, can I attend a party? So they do all their cases under daycare. So Singapore has certain norms where they don't admit the patient. Even if they put a drain, they just remove it off. So that time I got really convinced that this is like a daycare surgery, at least for decompression and discectomies. So this is how the sequence I met. This is Dr. Zhang Wei, then Dr. DJ Choi. He termed best biportal endoscopic spine surgery. He only uses chisel, no drill. With Dr. Sang Kyu Son and Dr. Liu Kim, Dr. Chul Wong Park, and finally Dr. Amol Rege, who has founded DMH UBE Academy and is training many students every 3 months. So why do we need to discuss adolescent lumbar disc herniation? So it is relatively rare. Accordingly, only 5% of the total lumbar disc herniations. And adolescent discectomy, it needs greater precision, tissue preservation, and careful tissue handling. Because if not done properly, the adolescent will have bearing on his physical health and mental health. So by definition, if we go, 21 will be the cutoff because epiphyseal cartilage fuses with the body around that time. And most of the cases occur between 13 to 20 years old. And the disc is not same like adult degenerated disc. It's more jelly-like, it has more hydration, and it is more difficult to remove. So MED has been standard operation for LDH for a very long time. But if you see the risk of resurgence in adolescent is around 11%. Then herein we thought, why not UB? Because magnified vision will allow us to protect the end plates more. So that's why we came up with a study to evaluate the clinical safety, efficacy, and functional outcomes of UB discectomy in adolescent patients who are refractory to conservative management. So this was a retrospective study and more than 6 weeks of failed conservative management for the patient. And the outcome measurement was done by VAS for back pain, leg pain, ODI scores, and McNabb criteria. And we have minimum follow-up of 1 year. So what is our technique? We do left-sided cases from left side and right from right. There are some surgeons in Korea who like to go contralateral and they do right side disc from left side. But we try to keep it simple, left from left, right from right, a 0-degree scope. And we always do hemilaminotomy and half butterfly flavectomy. And we use plastic cannulas designed by Dr. Park. He has gifted us some. So the transparent thing that helps us to protect the nerve root. We are able to see nerve root beyond the retractor. And the utmost care is no damage to the end plates. So not a very aggressive discectomy, preserve the annulus, because that kid is going to have full life ahead. So Epstein gave a classification, that's why we do pre-op CT in all our cases to identify the limbus fragment, which is quite essential to remove. And with endoscopy, it becomes quite easy to remove. So this case is left-sided disc, and the phleum is also different from an adult phleum. With UB, you can also identify the suspensory ligaments which are beneath the phleum. So never try to pull the phleum. Make sure the underneath of the phleum is free, and then only you can remove it. So the herniated fragment, after we remove, we should take care not to damage the annulus and end plates. So this is the plastic cannula which I mentioned. You can see the nerve root through the cannula. So it is just an added advantage, but the problem is the cost. Metallic one, you can autoclave and reuse it again. So this one fits to the sheath, to the scope, I mean. So the other case is right-sided discectomy. Right side is always difficult. Have some help in the initial cases on the right side, because drilling, because of the angle of the lamina, the right side case is always going to be difficult. So with UB, you can clearly identify the blood vessels on the dura. You can see the annulus. You can clearly differentiate the dura. And that is where the chances of neurological injury are reduced. And the goal is to preserve maximum of the normal disc. So usually these kids all have a lot of hamstring spasm, and they differ from adult disc herniations. They have less of back pain. And we always do thermoannuloplasty at the end. So we believe this reduces the recurrence rate. Here are some of the MRIs. This was case 1, 16-year-old male. The post-operative MRI after 6 months shows free nerve root. The patient was completely free, back to his routine activities. He was an athlete. So after 6 months, we can start his athletic activities. Another case, 17-year-old male. All our males were usually, their average height was around 170 centimeter, more than the average Indian height. 15-year-old boy, O5 disc, shows good nerve root decompression. So 2 of the patients in the case series of 12 had pre-operative foot drop, which went on to improve at 6 weeks. And our mean operative time is around 87 minutes. We mobilize all our patients on the same day evening and discharge them on the next day morning. So that makes the attenders and relatives they're very calming. The patient is discharged on the next day. So it feels like they are having a small surgery. So all the kids returned to their activity at around 4 weeks. There were no cases of early recurrence and also no recurrence in 1 year. There was one case of incidental durotomy in which we managed to put Tacosil. Unfortunately, it is not available in India, but we had got it as a gift from Professor Park. VAs for back pain and leg pain improved in all the patients significantly. Both the patients went on to improve neurologically at 6 weeks. There were no major complications, and according to McNabb outcome, all the outcomes for 12 patients were in excellent and good criteria. So this is VAs for back pain and leg pain. I'll just pull through this, and the ODI scores had improved significantly. So adolescent disc have greater proteoglycan content and they are more elastic. So UBE allows precise nuclear resection without annular violation. And there is minimal posterior element disruption. So, I mean, there won't be any phenomenon where we will hamper the growth of the child. And reduced tissue trauma translates to faster rehabilitation, return to academic and athletic activities, which are the priorities in adolescent population. And fluid dynamics, you need to be very careful about the fluid dynamics. One of the tricks to see fluid dynamics, always keep checking the outflow. You can see the dural pulsation is not very good. The outflow is not good. Whenever the outflow is good, the dura is quite pulsatile. So this pulsatile says that the outflow is good. So you cannot monitor the pressure, but these are indirect signs where you can know that the outflow is good or not. And outflow good is the basic criteria for continuing or starting your surgery. Without that, you cannot proceed. So limitations for it was a retrospective study, relatively a very small sample size and only a 12-month follow-up. So hereby I conclude UBE is suitable for skeletally immature patients. There is no interference with the future growth, and it may reduce recurrence and adjacent segment degeneration. This is our DMH UBE Academy. Last week we had a DMH UBECON where we performed 4 live surgeries. Professor Man Kyu Park from Korea and Professor Wu Peng Hung from Singapore. And this is the academy set up by Dr. Amol Rege, where we have simulators. The advantage of simulators is you have assured pathology in them. We have a stenosis model, we have a disc model, and we can give unlimited hands-on time to the delegates where they get familiar with, it's like a video game, where you need to know the controls, the foot control, the left foot controls the drill, how to stand, because when you start UB, you are going to have a lot of pain. So getting used to the system, how you stand, and then other part is I think everybody knows. Once you reach the lamina, all the surgeries are the same. Just a small clip from the simulator. So we took feedback, and these simulators also have bleeding in them. So, I mean, they were really happy with the way they could play. Thank you.
Thank you, Dr. Rohit, for a very nice presentation. We can take a few questions, if any queries from the crowd.
So, hello, Dr. Rohit. So, did you find the cause of herniation in these young people?
Sorry, sir?
Did you find any cause of herniations, a specific cause of herniations in these young people?
That's a good question. Most of them are athletes. So, and their height was around 170 centimeters. There was no specific cause. I think genetic predisposition is the first cause, but I mean, what I think is they were more active. One was a basketball player, another was a runner. So, I mean, those individuals who are very active, maybe that was one factor, but I think genetic predisposition is the main cause. Or maybe one of them was obese, with he was 6 feet 2 inches. But we couldn't exactly conclude what is the cause of it. Thank you.
Thank you. Because we have operated a 12-year-old girl, and she was not obese. She was thin.
12-year-old?
The cause of disc.
So what did you do for her?
We did UBE.
UBE.
Thank you.
So according to any advantage you felt, according to what was the advantage of UBE in an adolescent patient?
I think there is no such advantages. Just the scar is the thing only.
Okay. Thank you, Dr. Rohit. I would like to call the next speaker, Tho Bhanta, to present his topic, Transforming Neurosurgery Through Endoscopy. Dr. Tho Bhanta.
So good evening, Lady Excellency and gentlemen. I'm very great honor to be here as my second time. I'm Dr. Bhanta from Cambodia, so only one surgeon from Cambodia. And I come here not only for the conference, but I come here to share love, to meet my brother, especially Dr. Nikunja, Dr. Milan, that invite me as a speaker. So my topic today is about the revolution of the minimally invasive in Cambodia. So actually during my fellowship training, I was trained in France for 2.5 years. During that time, there is no endoscopic even spine surgery or brain surgery, except we did the ETV for the hydrocephalus. But most of the time we don't have. So after I come back to Cambodia in 2019, so everything is open surgery. So we start to learn the endoscopic surgery in 2023. So there are some doctors in different hospitals that they go to train in Korea. Especially Korea, we have a good cooperation with Cambodia. So my friend, as you see in the picture, he go to train in Korea for 3 months in 2025. So in my department, we start the UBE when he come back. During that time, I went to Thailand to learn monopoctal. So I do monopoctal, he do bipoctal, so we combine together. But in public hospital, we have only UBE. And monopoctal I do in a private hospital. And then one of my friends in 2026, he go to Korean again to train for a short term, just only 1 month to learn the endoscopic, both UBE and monopoctal. So since we have endoscopic in our public hospital, until now we do around 100 cases. So we can say that in Cambodia, endoscopic is quite young, but we are happy that we can do minimally invasive to improve the quality of life of the patient. And we organize the endoscopic training every year in Phnom Penh. So we invite professors to join to train with the sample from the pig. So we can do both UBE and monopoctal. So this is the picture that we do the UBE in our department. The patient is 47 years old female. So as you see in the picture, she has L4, L5 hernia. So we did UBE for her. So the duration of the surgery is quite long as a beginner, but the outcome is excellent. The patient stay only 2 days in the hospital. So that is another case that, as you see, L4, L5 hernia. And if I compare the scope, the view, I can say that the UBE have a good visualization, the view better than the monopoctal. Okay, beside that, we do the cement injection as everywhere did. Percutaneous screw fixation in case of the spine fracture that there is no neurological deficit, there is no canal compression. So although that can we do in the private clinic, so I cooperate with the Thai doctor, so we did outdoor tele for some patients as you see in the picture. Even we can do combine with PSLD in other level as well. So besides spine endoscopic, we do brain endoscopic as well. As Dr. Charlie Teo, he's one of my favorite professor that he came regular to Cambodia to do to train me, to help me to do the brain surgery. In that picture, he was stay in my orphanage where I grew up. So he come to the hospital, he shared the lesson, and he joined the operation with me. So we do several cases together. But since last year, he did not come. I think he's busy or tired. So no, I don't talk about that. I just share about some cases that I do endoscopic. So I go quick because time is limited. Okay, like this case, like keyhole surgery through the eyebrow approach that we do minimally invasive combined with, we can put the endoscope inside and to see how the tumor is complete, to see complete removal or not. So I use 30 degrees almost in all brain case, even in the tumor, in the hematoma, so always use with the endoscopy. As you see in the picture, the pre-op and the post-op operation. Like tumor, okay. Okay, very small incision. We do small incision to remove the tumor and completely by endoscopic. Okay, in the third ventricle, through the trunculus approach, CP angle tumor. Okay. Even in the microvascular decompression, I also use the microscope to confirm if there is the double loop compression or not. Endonasal approach by endoscopic, I do with the ENT surgeon. Okay, even with the cystinostomy, I invite Algerian to come one time and to talk, to share about brain surgery. So I do just small opening and then put the endoscope in and so see the, to do the, to put the drain between the carotid and the optic nerve. So the result to the post-operation. Okay, thank you very much for your attention.
Thank you, Dr. Thovanta. We have heard that Dr. Raj is not here. So we'll proceed with another presentation by Tej Prakash Tawadi, Reoperations after UB.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Nikunj and the team for organizing such a wonderful conference and for having me here. I am Dr. Tej Prakash Tawadi, and today my topic is the reoperations after lumbar UB surgery. Should we really worry? There have been there are cases that requires revision surgery even after UB like any other spine surgeries. So how is the number? Is basically the literature review to go. In spine surgery, I think we should never say it's 100% guaranteed, like other people, some people we often hear saying this. So we have seen the global surge in spine surgery, and in US alone, around 1 million back surgery are done every year. So with the changing trends, the open surgery has been shifted to micro and recently to the well acceptance of spine endoscopy. So although there have been recent advances in the surgical techniques, better fusion technology, better implants, better biologics for fusion, still reoperations are high in spine. And these are the pictures we often see in our clinical practice in our OPDs. So why reoperations are more in spine surgeries? In spine, it's not always that reoperations means surgical failure. It might be the disease progression itself. So there could be reherniation. There could be instability due to the decompression, enough decompression to free the nerves, preserving the enough facet. So incomplete or inadequate initial decompression, multi-level pathology, and adjacent segment disease. So why reoperation matters? Every reoperation may signal technical failure, incomplete decompression, recurrent herniation. Reoperation risk shapes patient counseling, especially particularly in diabetes and high BMI patient, reoperations are high in such patients. Comparing the techniques UB with other modalities of surgery and understanding the causes guides prevention strategies. So broadly, these have been classified into early versus delayed, planned versus unplanned, index level versus adjacent level. In the early reoperations, early versus late, broadly it has been it has shown to be bimodal distribution below 6 months and after 6 months. In the paper by Sin et al., early group, the mean interval to operation was 3.15 months, and the late group had mean interval to reoperation of 10 months. So overall causes of reoperation, the post-op instability was the most common one, accounting 45%, incomplete decompression in 25%, recurrent disc herniation in 11%, facet cyst in 10%, and secondary restenosis in 8%. In early group, there was the overall. So in early group, it is the most common is the incomplete decompression, and accounting 40%, post-op instability is 22%, recurrent herniation in 13%, and secondary restenosis in 13%. So we all know the early phase surgical hazards and common pitfalls as complications are high in the early phase. So inability, these are particularly due to inability to establish the stable triangulation, poor visual field management, inadvertent overboring of the facet, and dural tears. So this is another paper by Lee et al. Where at 90 days, the reoperation rates have been found to be 3%, and the most common cause being the recurrent disc herniation, around 83% almost, and 84% in 90 days. So incomplete decompression is the most common one in the early phase, and anatomical hot spots are the key aspects which we need to consider, particularly the axillary type herniations where the disc gets tucked under the traversing knob root, high-grade migrated discs, subligamentous migration beyond the interlaminar window, and foraminal and extraforaminal regions, inadequate scope placement during paraspinal approaches. So other cause is epidural hematoma. This has been well reported to be as high as 24%. However, only 1.2% have required surgery in the paper by Ang et al. In the long-term reoperation groups, that's more than 6 months, the long-term cohorts, the most common cause was post-op instability, and they're accounting for 72%, and facet cyst 11%, recurrent herniation 8%, secondary restenosis 5%, and incomplete decompression only 2%. In the late group, incomplete decompression is quite rare. So post-op instability, we all know it's due to the facet violations, and less than 30%, around 30% of facet joint medial IAP resection is well accepted for the, and that is required for the standard lateral recess decompression. However, sometimes in the crowded facets and more stenosis cases, we tend to resect more of the facets, and more than 50% facet resection may cause iatrogenic segmental instability, and ultimately leads to collapse, listhesis, and dynamic radiculopathy over time. So these are some pictures where there have been good amount of facet have been preserved in this X-ray, but on the other one, we can appreciate the more aggressive resection of the facet leading to instability, which ultimately required fixation. So what are the clinico-radiological factors that predicts revision surgery after UBE? It's the strongest predictor is the facet joint osteoarthritis. So severe preoperative facet joint osteoarthritis is indirectly suggests late instability, and long-term reoperation is quite common in these groups, as shown by the studies. So another factor is the disc degenerations. It's the foramen grading. So in the when there is advanced disc degeneration, similar with the facet joint arthritis, there is significant disc height loss, altered biomechanics, shifting mechanical loads to the facet joint, and ultimately the facet arthritis. And the literature shows high rates of reoperation in the advanced degenerative case. Coming to the systemic factors, the risk factor, diabetes is the most common, and there is significant association of reoperations and high complications with the diabetes mellitus. It reduces protoglycan content in the intravertebral discs, weakens collagen matrix integrity, impairing tissue healing, and accelerating disc degenerations. Other associated factors are hypertension and smoking. The non-predictive factors for reoperations are age, sex, modic changes, and high intensity zone, and segmental angulation and translation. However, this BMI, prolonged preoperative signs and symptoms, and depression, they have shown high complication rate. However, they are not predictors of reoperations. So what determines the outcome after UBE? Actually, it's the facet joint arthritis. To have good outcome, more than 66% of ODI. So advanced osteoarthritis in the facet joints have 18 times more likely to achieve significant 24 months functional improvement if less arthritis group. Facet osteoarthritis grade 0 and 1. So minimizing failure, we have to make the decompression checklist, systematic root tracking, explore the axilla, fluoroscopy, use adequately, and proactive post-op imaging. Mitigating the long-term failure, the 30% facet resection rule, incline drilling on the contralateral approach. So preoperative tries to avoid reoperation. In the early facet osteoarthritis group, foramen grade 1 to 3, and no instability, then only discectomy might suffice. However, with advanced arthritis and advanced degenerated discs and diabetic cases, fusion might be the better options. These are some papers which have shown the pooled reoperation rate of up to 8.5%, and the other 10 years reoperation rate in Korean study up to 16%. The similar Japanese data shows 10-year reoperation rate of 16%. However, this meta-analysis shows 8.5% in open discectomy. Monoportal has 16%. And the other monoportal meta-analysis was 9.79%. However, UBE in the meta-analysis shown to have 7.7%. This is my case where I think I did adequate decompression, but patient was doing fine, but at the end of 7 months, I had to reoperate because of the re-stenosis, or I might have left some discs over there, so I have to fuse it. So to conclude, should we really worry? Actually, we should say no, but vigilance is required. The reason being the reoperation rates are decreasing, and the different papers has shown from the 2016, Choetal have reoperation rate of 7% in these are UBE cases. The reoperation rate in UBE are decreasing from 7.7% to say GSA and Lee et al. 3%. However, the recent meta-analysis has shown up to 7.7%. Reoperation rates are lesser than other modes. Better understanding of complications and techniques, and revision UBE for recurrent lumbar disc herniation is safe and effective than open. These are my references. Thank you.
Thank you for the nice presentation, Dr. Tes. I think the session is end. Do you have any question?
Thank you so much, Doctor. May I now request Professor Lal Regman sir to present the token of love as a gestures of appreciation and gratitude to our esteemed speaker. To receive the token of love and a certificate, I would like to welcome our speaker, Dr. Prakash Kafle. Dr. Muhammad Asad Javed. Dr. Muhammad Asad Javed. Dr. Rohit Kaviswar. Dr. Tho Vantha. Dr. Tej Prakash Dawadi. Dr. Muhammad Asad Javed. Dr. Prakash Kafle. Dr. Prakash Kafle. Dr. Ramesh Sikagoli. Dr. Ramesh Sikagoli. Dr. Prakash Kafle. Now, I would like to welcome our moderator panelists to receive the token of love. Dr. Chandra Prakash Limbu. Dr. Prakash Kafle. Dr. Somraj Lamithane. Dr. Pankaj Raj Nepal. Dr. Rajiv Pandit. I'd like to request our panelist and the speaker for the photo session, please. Dr. Prakash Kafle, Dr. Mohammad Asad Javed, Dr. Rohit Kaviswar, Dr. Tho Vantha, Dr. Tej Prakash Dawadi, Dr. Chandra Prakash Limbu, Dr. Rajiv Pandit, Dr. Somraj Lamichhane, Dr. Pankaj Raj Nepal. Due to the shortage of time, we have postponed the panel discussion for tomorrow. It is truly an honor to stand before you and contribute to such an amazing event. I am grateful for the trust, support, and encouragement I have received throughout the program. With this, I would like to hand over the session to Dr. Pratik and Dr. Uma. Thank you.
Good evening, ladies and gentlemen. It is my distinct honor to invite our chief guest, Dr. Gopal Raman Sharma, and our respected guest of honor to be seated at the front row. Dr. Basanta Panta, Dr. Krishna Sharma, Dr. Prakash Bista, Dr. Rajiv Jha, Dr. Madhu Dikshit Devkota, Dr. Bal Gopal Karmacharya, Dr. Nikunja Yogi, Dr. Amol Rege, and Dr. Chingfeng Hu.
Announce names. Please be seated in the front row, please. Thank you.
Dr. Basanta Panta, Dr. Krishna Sharma, Dr. Prakash Bista, Dr. Rajiv Jha, Dr. Madhu Dikshit Devkota, Dr. Bal Gopal Karmacharya, Dr. Nikunja Yogi, Dr. Amol Rege, Dr. Chingfeng Hu.
Ladies and gentlemen, may I kindly request everyone to rise for the national anthem.
थुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली सायौं थुङ्गा फुलका हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचल वीरहरूका रगतले स्वतन्त्र अटल ज्ञान भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
Before we proceed with our program, I would like to invite everyone to join us in observing 1 minute silence in the remembrance of those who tragically lost their lives in flood over the past few days. Let us use this moment to pay our respects to the victims and to express our deepest solidarity with their families and with all those affected by the devastating tragedy. Thank you.
Thank you, ladies and gentlemen. Now, as we formally inaugurate ISUBE South and Southeast Asia 2026, we would like to invite our honored dignitaries to participate in the ceremonial lighting of Diya. Dr. Balgopal Karmacharya, Dr. Nikunja Yogi, Dr. Madhu Dikshit Devkota, and Dr. Gopal Raman Sharma. Can we please have you on the stage, please? Thank you, everyone. Now, I would like to request Dr. Madhav Gautam to please put on khada to our respected guest of honor and chief guest. Dr. Madhav is our senior-most anesthesiologist of Nepal. Please give him a big hand. Thank you so much, Madhav, sir.
It is my absolute honor to invite our chief guest, Dr. Gopal Raman Sharma, to address this gathering.
President of NESS, second UBE, Dr. Balgopal, and distinguished dignitaries, Madhu ma'am, Nikunj, and all my friends, ladies and gentlemen. It's my privilege and great honor to be here in this second UBECON and the first International Society of UBE South Asia and Southeast Asia being held in Kathmandu. So I'm very much thankful to Dr. Balgopal and Nikunj Yogi and entire organizing team for this generous invitation and to address this August gathering of prominent neurosurgeons who have been involved in UB spine surgeries. And I'm very much thankful to all of you. And I believe that cadaveric workshop, the scientific session which has been carried out were educative, interactive, and meaningful. I see for last couple of years this UB spine surgery is growing very fast in Nepal, and most of the young neurosurgeons, the orthopedic and the neurosurgeons, they are very eager to learn this UB spine surgery. And Dr. Balgopal, Nikunj Yogi, and other my fellows, they are leading this project to educate this young new generation. And I hope and this will be continued for a long time. And this second UB is one of the example of this action. So, you see, I'm a neurosurgeon who have been doing microneurosurgery for a whole life. So, I don't find any difference between microsurgery and this endoscopic surgery. And I don't find any difference in between these two techniques. However, if you look at the endoscopic surgery, what I find is the patient will have minimum scar, less hospital stay, and this tissue damage, especially the muscles damage, will be less, and maybe the patient will join their previous job earlier than the microdiscectomy. So, but at this age, you see, I can't switch over to the endoscope. That's true. I love my microneurosurgery, so I can't quit it. But for the young neurosurgeons and the orthopedic surgeons, my advice is you should adapt new technology and technique. If you leave it, you will be left far behind. And the other thing is that, you see, I have done thousands of, the microdiscectomy in my life, and still now, many UV failure microdiscectomy, they come to me, especially with persistent pain, despite the UV surgery. And I explored in most of them, and what I found was that in some cases, the disc was not inadequately removed. And in many cases, you see that there was lateral root canal stenosis and the lateral recess stenosis are not being addressed. So I advise my colleague that if you are doing UB discectomy, then you should not only you should remove this disc, you should also remove, you should also address the lateral recess stenosis and the root canal stenosis as well. Otherwise, I think microdiscectomy and the UB discectomy, they seem similar. And if you work hard, you see that if you are dedicated to UB and if you are diligent, right, and if you are honest, then probably after some time, after some years, you may, surpass the microdiscectomy. But maybe after 10, 15 years, this UB will be surpassed by the another technology. probably the robotic surgery, we don't know. So I'm very certain that this conference will act as a platform to share our knowledge, experiences, and to collaborate ourselves for the promotion and foster of this UB surgery. And I'm always with you, and whenever you need my assistance, I'm not against UB, that is true, okay? I always promote new technology, new technique, and juniors. You don't have to worry. So my help will be always there, and I wish this, the conference is going to be a big success. Thank you so much indeed being with me.
Thank you, sir,
for your insightful and inspiring address. We're truly honored by your words and guidance. Now, I would like to invite the President of NES to address this distinguished gathering, Dr. Bal Gopal Karmacharya.
Good evening, all. Chief guest, Professor Dr. Gopal Raman Sharma, Professor Madhu Ma'am, Professor Hu, Dr. Amol, Professor Regi, Dr. Nikunj. I take this opportunity for thanking you all for coming to this conference. So at this moment, I'd like to remember Professor Malcolm Pestonji, who was my mentor and who introduced me to UBE surgery. So I had a short mentorship with him during the COVID peak time. And me and Dr. Nikunj started this technology introduced in Pokhara, and he has come to Kathmandu. And now he has propagated it further. So I remember we used to go to other places to learn about new technology. Now a lot of our colleagues from other countries are coming to Nepal to learn this technique. So that is a big, big achievement for us. And I hope with the continuous contribution of all the neurosurgical community, both seniors and young colleagues, and also a lot of orthopedic colleagues who are taking up spine, we would be able to provide the best optimum care for Nepalese patients. And thank you once again, and I hope you will have great academic fiesta and then the social programs, and also I hope that our friendship will continue in the future. Thank you all.
Thank you, Doctor, for your gracious and insightful address. May I now invite Senior Advisor, ISUBE South and Southeast Asia, Dr. Anmol Riji, to address this conference.
Good evening. First of all, I thank Dr. Nikunj Yogi, Dr. Bal Gopacharya, and the Upendra Devkota Memorial Hospital staff, and all the societies for inviting me here. I am really honored and privileged to be part of ISUBE SSEA chapter, and I am very grateful to the President for taking me on the advisory board. We are living in an era of Instagram Reels, Facebook posts, and WhatsApp status. And every surgeon I can see in my place who completes his training next day wants to be a UBE surgeon, and he immediately in a week's time will post on his status that he has done a UBE. By end of 1 week, I can see a butterfly on his status. So that is what is happening. So it is very important that this society will take the responsibility of teaching and mentoring these young surgeons. Otherwise, UB will go into disrepute. If you're orthopedic surgeons, you may have heard about the Elizarov technique and what happened to it. Everybody was using Elizarov right and left, and eventually it fell into disrepute. So it's not the technique which goes into disrepute, but it is the training. If you don't teach and train surgeons properly, and then they will use it right and left, and it will fall into disrepute. So it is our responsibility to see that that does not happen. At the last UBES meeting, one senior-most professor from Seoul presented a series of cases of UB surgeries which were done either for unindicated cases or done halfway or done improperly. So he presented he works in a tertiary care hospital, so he presented all these cases. So the same thing can happen just like Elizarov to UB surgery if we don't deliver it properly. So it is our responsibility, the pioneers of UB surgery, the teachers, the mentors, to see that this young generation is properly taught. And I think ISUBE SSEA chapter will take that responsibility. I can see the great enthusiasm. The participation in this conference from Southeast Asia is tremendously increased, and it is going to grow in leaps and bounds. So we'll play that role in mentoring and teaching. Thank you.
Thank you very much, Dr. Rege. Now, I would like to call Dr. Chingfeng Hu to present the Presidential Medal to founding President of ISUBE South and Southeast Asia, Dr. Nikunj Yogi. Can we please have them on the stage, please?
For the development of and the progress of UBE in Nepal, UDM NINAS has played an exemplary role. So far, they have been successfully conducted 12 UBE training courses. Let us now see the video of the institution and their efforts in making the UBE in the top of the map of Nepal.
It began with a simple but powerful vision that no Nepali suffering from a complex neurological condition should have to leave their own country to be healed. A vision Professor Upendra Devkota carried home and built into an institution of service, training, and research. For 2 decades, UDM NINAS has carried that vision forward. Stroke, epilepsy, brain and spinal disorders, neurological emergencies and trauma, neurotology, mental health and rehabilitation under one roof.
Of Professor Upendra Devkota, who was Nepal's pioneering neurosurgeon and the founder of this National Institute of Neurological and Allied Sciences, which is now dedicated after him. He believed that our people deserve the very best and that Nepal could contribute towards advancement of neuroscience at a world stage. We are committed to combining the state-of-art technology with the expertise of highly skilled professionals so that we can give the best quality care to our patients.
As medicine evolved, so did what we could offer. Inside our operating theaters, the Kenevo microscope, O-arm imaging, and real-time neuronavigation worked together, giving our surgeons the precision to reach what was once unreachable. Every nerve pathway is watched live throughout surgery through continuous intraoperative monitoring because in neurosurgery, there is no margin for uncertainty. Our biplane cath lab, the first of its kind in Nepal, opened stroke and vascular care to patients who once had no option at all. It was here that unilateral biportal endoscopy, UBE, found a home in Nepal.
UBE, or the unilateral biportal endoscopy, is a new generation endoscopic spine technique. In UDM Ninans, we started this technique in 2022. And as our experience grew, we thought that it is very important to share this experience and knowledge with surgeons around in Nepal and around the world. Since 2024, where we gave them a practical hands-on experience to create a meaningful opportunities for surgeons to learn UBE through a direct hands-on experience, so that they can give their patients back at their home countries a meaningful, a safer, more precise and minimally invasive spine care. Today we are proud to have trained more than 60 neurosurgeons and spinal surgeons across the globe, and we are happy that they have gone back to their own country and started UBE services through the knowledge, skills and confidence they have gained through their training in Nepal. And now we are delighted to take the next step beyond training, that is towards regional collaboration and leadership.
But our journey at UDM Ninas goes beyond training and technology. At the heart of everything is our ethos, patients first.
Our patient-centric approach begins by understanding the person, not just the disease. Every patient who walks through our doors brings a different story, a different need, and a different journey. But each carries a shared hope to heal and return to a better life. From diagnosis to treatment, rehabilitation and recovery, we bring together specialized expertise, advanced technology, and multidisciplinary care to provide what is right for every patient. Every successful treatment is more than a medical outcome. It is a family reunited with hope and a patient placing their trust in us. As we continue to advance neuroscience, we remain committed to strengthening education, research and innovation so that our patients can receive the best care today and for generations to come.
But UDM Ninas was never built only to treat. It was built to train. And today, surgeons from across South and Southeast Asia come here to train, as Nepal now leads the region in advanced spine techniques. 2 decades on, that journey continues.
Now, I would like to request Dr. Nikunja Yogi, President ISUBE South and Southeast Asia, and Ms. Fair Zhang, Director of Global Market Bonds Institute, to kindly come forward and present a certificate of appreciation to Professor Dr. Madhu Dixit Devkota, Chairperson of UDM Ninas. This recognition honors her outstanding contribution to the advancement of UBE and her visionary leadership in establishing UDM Ninas Nepal as a distinguished center for UBE training, education, and academic excellence. Can we please have you in the stage, please?
I would now like to invite Dr. Nikunja Yogi and Ms. Fair Zhang to provide the certificate of appreciation to Mr. Milan Gurung, CEO of UDM Ninas, for his contribution to the UBE training courses in UDM Ninas, Nepal. We'd now like to invite Professor Dr. Madhu Dixit Devkota to share her insights with us. Thank you.
Thank you, all of you present in this very special evening for us. I feel a little overwhelmed, and I accept your appreciation with a lot of gratitude and humility. And not for myself, but I would like to accept this on behalf of our team. Our team that has given me this position to come here and stand before you. It is quite overwhelming, I must say. At the outset, I would like to thank the founder of our institute, the father of modern neurosurgery in Nepal, and a man who carried a huge responsibility of being the only neurosurgeon for the entire country till he trained his own neurosurgeons. I'm so proud that his legacy continues to inspire us every day at our institution. He was one committed human being who believed in technological advancement, who always told us that, the skills that you learn, the advancements that you make, you should not hold it to yourself. You must pass it on. The responsibility of learning something, comes with a huge challenge of passing it on, refining it, and then bringing it to the people that matter, your patients. And that goes the motto of our institute, patient first. Thank you, team. Especially, I wouldn't dare call you my boys, but that is what Prof used to call all of you. He would call his trainees my boys. So well done, Dr. Nikunj Yogi, his boy, for this great feat today. I remember when Nepal hosted the first South Asian conference in Kathmandu, and there were stalwarts like Professor Tandon, Professor Banerjee, the foremost professor from Bangladesh, Pakistan, and they told the audience that Devkota should lead, he should be the founder president of the newly formed SARC Neurosurgical Society, which I bet all of you are members of. So I almost feel like the baton is coming back to us with Nepal leading the process, and our neurosurgeon, Dr. Yogi, becoming the founder president, and our very dear Dr. Balgopal leading him, pushing him from behind to his position. Thank you so much, Dr. Balgopal Karmacharya. It means a lot. I could go on and on, but I would just like to say that those of us who are neuroscientists ourselves, like you, and those of us that support, change is inevitable. And change to progress and to bring in new technology is not a choice for you. It is your duty. Thank you so very much.
Thank you so much, ma'am. Now I would like to request Dr. Madhav to please come up on the stage to provide a token of appreciation to our OT in charge nurse, Sister Jyoti Thapa, on behalf of all the nurses involved in the UBE training program at UDM Ninas. Thank you, sir. Now I would like to call Mr. Pujan Khatiwada to come up on the stage to take his token of love for his contribution in the UBE training program at UDM Ninas.
Now we'd like to call upon stage Professor Hu, Ms. Fair Zhang, Dr. Anmol Rege, and Dr. Nikunja Yogi to receive their letter of appointment. Thank you.
I would like to call Dr. Wu to provide the executive member certificate to Dr. Amul Rege. यो चाहिँ कसको लागि हो सरको लागि ल ठिकै छ Now I would like to call Mohammad Asad Javed. Now, I would like to call Bala Raja Sekhar to receive the executive member certificate from FAIR. Provided. Okay. I would like to call Dr. Punit Gridhar to receive the executive member certificate. I would like to call Dr. Vishwaranjan Naik. I would like to call Sai Kalyan. Dr. Sai Kalyan. I would like to call Dr. Ashutosh Kumar. Dr. Ashutosh Kumar. I would like to call Dr. Dattaraj. I would like to call Dr. Balgopal Karmacharya. I would like to call Dr. Nikunja Yogi on the stage. I would like to call the Professor Dr. Hu to receive the certificate. I would like to call Dr. Somai Elmore on the stage. Samay Elmore, yes. And request him to facilitate the program with Dr. Nikunj Yogi. I would like to request to Dr. Samay Elmer to say a few words.
Good evening to every one of you. It's a great honor and a pleasure for me to be in second time in Nepal, Kathmandu, and grateful and very delighted that my brother, since I have met him in India first time, and he is a great pleasure to be the first president of UBE Society Nepalese. As a chairman of Ambassador Committee of World Federation Neurosurgery, the biggest international federation for neurosurgeons across the globe, and the founder of AWNC, it's a great pleasure that my dear brother Yuji have invited me to this successful event, and I wish him all the best all the time, because training of all our colleagues is a mission that not everyone can do it. It needs effort and tremendous effort that continues every day to continue the chain of our progress. It's not only that you are the best surgeon in the world, that need nothing if you didn't give this experience to your young generation to continue the progress. It's not a one-man show, it's a team show. And the team makes the leader have every effort all the day and night to make his boys, as my dear friend said, get bigger and bigger. And it's a great pleasure. When I was sitting here, my dear lady said, it's a great honor for me that my students now are presidents. It's a great pride for the teacher that saying his students get bigger and bigger. And now I'd like to congratulate all the team. Every member of you have done a great success, and I will transfer this to all international societies that I am here to represent them. Thank you all, and more success in the future.
I would like to call Dr. Nikunj Yogi and Dr. Rasul on the stage. Dr. Rasul Jo. I would like to Dr. Rasul Zone to say a few words.
Thank you very much for everybody to keep staying here even it's evening. Thank you very much, Dr. Nikunja, also, Bala Sir also, all of you invited me, and believing my experience that giving me chance to show my skills here, even in OT. You allow me to do the surgery myself, so I'm proud of you. When I meet you in India first time, I feel that you are very interesting in the new techniques. When I'm showing something, you're asking double again. Show us what's the question you have. I didn't expect that you are inviting me to say something, so I'm sorry. Thank you very much for inviting me, and I hope to continue this collaboration and agreement. I will try to arrange some meeting in my country also. You can send some students, we can try to teach, and we can send some students to come here to see how you are doing here. So really appreciate your job is excellent. You are doing excellent, and I will keep in contact with you always, and hope to see you in Uzbekistan next year in our conference. Thank you very much.
I would like to call Professor Dr. Madhu Dikshit Devkota on the stage to provide the khada to our scientific chair, Professor Dr. Prakash Dafle. Now I would like to call all the scientific chairs and our executive members on the stage for group photograph. Dr. Nikunja Yogi, Dr. Balraj Sekhar, Dr. Sai Kalyan, Dr. Amul Rege, Dr. Ashutosh Kumar, Dr. Vishwaranjan Nayak, Dr. Bal Gopal Karmacharya, Dr. Punit Giridhar, Dr. Rasul, Dr. Ramesh Sikagoli, छैन उहाँको छैन
I think we missed one of our member, Dr. Ramesh Sigakoli. Ramesh sir, can you come up to the stage, please? Dr. Ramesh Sigakoli. Oh, yeah.
Now we are at the end of our session. I would hand over the mic to Professor Dr. Prakash Kafle for the closing remarks.
Good evening, everyone. Respected Chief Guest, Professor Gopal Raman Sharma sir, Professor Madhu Dixit ma'am, President ISUBE SSEA chapter, and President of UBECON Nepal, Dr. Bal Gopal Dai, and all the delegates. It gives me an immense pleasure to invite you all here. It was UBECON 2 as well as ISUBE SSEA chapter conference. It would not have been successful without your presence and dedicated team. And I wholeheartedly thank UD Ninas for all the supports and our President Nikunj Yogi and for his leadership. It was a great event starting from yesterday with cadaveric workshop, and it was a great academic fest which is going to be held on the coming days as well. It was a great learning experience. When any new things or new technology comes, it's always necessary that we share each other's experience, which have been done today. So thank you all for your generous presentation, and thank you Gopal Raman sir for gracing the session. So it's our pleasure, and thank you all the participants, media house, the pharma lines, hotel, hospitality, everyone for your generous support. Without your good hospitality, the program would not have been this successful. And I take this opportunity to thank you all for your presence. With this, I would like to welcome you all again for tomorrow's academic fest. And most of all must be hungry. So with this, I would like to in the today's formal opening ceremony. Thank you.
I would like to request everyone to come in front for the